And I think on that wonderful note, we are ready to get started. So first and foremost, I want to welcome all of you to this next session of the Crisis Jam. I'm Brian Sims. I'm with NASPIT, the Senior Medical Advisor, and I am thrilled to be your host again for this version of the session on Crisis Jam. Today, and before we even get started, I want to give thanks to all of you for joining us on the line. I would do my shout outs as I always do each time I host, to give special thanks to wonderful interpreters that we have that really broaden this message and are able to get it out to so many additional individuals. So we're thankful to all of them and thankful to all of you for joining us. On this first slide, what you will see is kind of the direction that we're all headed in. Many of the states that we talk to have spoken quite a bit about attention being paid more so to this crisis implementation and intervention component, focusing on youth, particularly with youth mobile crisis. So we're going to be hearing from a wonderful speaker today, a little bit later on, but it is just a highlight to let everyone know that this is a major focus in terms of its implementation. So could we go to the next slide, please? And as all of you have seen this particular slide, and it's just a reminder to all of us that we are still looking for states who have been identified as including Medicaid. So if you look at this particular slide and you feel that your state should be in red, please don't hesitate to get in contact with Karen or otherwise through the office so that we can update this particular slide. It also identifies, again, the tremendous response that we have from everyone who has been responding, who has been coming on board. We are now looking at well over 400 people who are joining us on a weekly basis. And we are so thankful for all of this because this is really an indication of where this crisis intervention services are really headed. We're going to ask that as you are looking at these slides or otherwise, please at any point in time, if you have any questions or otherwise, place them into the chat box area. Next slide. And this is a particularly familiar slide for everyone. This is our landing page where you talk about talk.crisisnow.com, and you can access a tremendous amount of very useful information. As I'm sure as many of you have already touched this site and have seen it already. It also points out things that are happening today, like you can see in the top corner, but also links that will take you to previous versions. So you get a chance to kind of catch up on things. If you had missed a particular session, it's a really valuable slide to kind of work with. Next slide, please. On the highlights that you'll see, again, we're moving in the direction of taking a look at what is out there right now, what we're working towards, what the states are doing, what many of the systems are doing. And you can find a lot of that information. But I want to put more of a focus on the top left to talk about the 988 Crisis Jam learning community. This has been the development of this crisis calculator. That is something that has really sprung up, and you're going to hear quite a bit more about it as we go through this particular session. But it is something of note because many of you have been asking about it, and since it's already been in place now, we'll give you a tremendous amount more information that could be helpful. Next slide, please. Now, as the articles that have recently come out, you can see that attention is growing. In this particular article, it highlights that the pandemic itself has made people heighten their focus on mental health care as this 988 is coming into play. So it is just an acknowledgement again of the strength of acknowledgement that we have more people coming on board, looking at the crisis intervention services, looking at early intervention and being able to be available to all communities in an equitable fashion. And it also highlights about workforce capacity, because this is something that many of the states and otherwise have identified as issues. So it is in the forefront of our understanding and needs to address. Next slide, please. And this particular one, again, opens up the door to understanding that there are many also other opinions as well. And these are interesting articles because when you're looking at implementing something new, invariably you're looking at those who embrace, those who understand, maybe some who don't understand or otherwise, but charities are contributing to this growing mistrust of it. And this is a particularly nice article to kind of dive a little bit deeper to see where this is, because it may be something for your area. It may be something that you may want to focus a bit more on. Next slide, please. And the quote of the day comes from Congressman Tony Cardenas on the launch of the new bipartisan House Bill 988 and Crisis Service Task Force. And in it, it says, together we can work towards a future where mental health and substance use crises, just like any other kind of medical emergencies, receive the care they deserve with someone to call, someone to come, and somewhere to go. And this is really overarching and cross-cutting with what Samsa has pointed out. So it is a very, very good quote to really substantiate and embody what we're really looking at in terms of crisis intervention services. Next slide, please. At this point, we are ready to go into our feature presentation for this morning. And we have the honor of having with us today Tim Marshall, the Director of Community Mental Health, Connecticut Department of Children and Families. And he's going to be speaking to us along with his colleague on mobile crisis intervention services in Connecticut. So I will turn it over to Tim. Good morning.
Great, thanks. Next slide, please. So good afternoon, everybody. Thank you for the invitation to join you quickly here. Just a quick review of the Connecticut model, and then we'll hear from my colleague, Jeff Vanderploeg, on the data. So Connecticut has 3 components to their child-serving mobile crisis system. We have a statewide call center, and that call center is also the call center for the adult mobile crisis system, and they are also the call center for the coming 988 and the Lifeline. We're currently beefing up quite a bit of a capacity there to handle the increased volume that we anticipate. So the call center is a basic component of it. We have 6 primary contracted providers with 14 sites. And then the last strong component of our whole overall program is a performance improvement center. And you'll be hearing from our data and our analytics from Jeff in a moment. But it is a statewide system that's for anybody. It's a community-based system. It's family supportive, and just anybody can call for no fee. We define it by a just go mentality, or that the crisis is defined by a caller. So we are purchasing a face-to-face assessment. As I said, it's free of charge and it's rapid. We expect our providers to be face-to-face within 45 minutes, 80% of the time. And just before the pandemic, we had an average time of 30 minutes face-to-face. And it's all staffed by master's level clinicians. The next slide just shows a map. So our provider community had to be very strategic about where they located themselves so they could make sure that they get to every town and city that they service within that 45-minute period. And all 169 towns and cities of Connecticut is shown. If you're not familiar with Connecticut, it's a small state, probably the size of a number of counties. So it's about an hour from north to south and 2 hours from east to west. So it's a small geographical area. Next slide. And so we are primarily respond to homes, school, and emergency departments. Those are our top 3 referrals and the top 3 locations we go to, but we'll go to any location where a child is at, including public libraries, McDonald's, a corner. We service kids just about anywhere in the state. We do have a crisis stabilization component. So after the acute phase of the crisis is stabilized, our provider system can work to up to 45 days with under the same episode of care, linking the child and the family to longer term services. During this COVID period, we are seeing less of the long-term linkage just because of the need on the front end has been so great. We do a specific diversion to EDs and inpatient and other high end service categories. We do a full statewide uniform crisis assessment. It's a uniform crisis assessment doc that we developed with all of our providers together a number of years ago. We do use a number of standardized instruments within that, and they have specialized instruments at their disposal if need for like eating disorders or substance use or family violence if necessary. We also do have psychiatric services and medication management available within the contract if needed. And we do work on quite a bit of collaborations in the community with EDs, schools, police, law enforcement, and other. Next slide. And then Connecticut is really working hard to beef up our system. We are currently Monday through Friday, 6 a.m. to 10 p.m. when we're face-to-face. All the other time we do a phone assessment and on the weekends 1 to 10. But we are right now in the midst of going 24/7. So we're amending contracts right now. We're adding funding to everybody so we can go 24 hours, 7 days a week, face-to-face for the entire year. We're also, Connecticut is adding currently right now, just beginning to procure for a 23-hour behavioral health crisis assessment center with an accompanying state crisis stabilization beds of 0 to 14 days. And finally, we're looking at adding geotracking and real-time appointment scheduling to enhance our system. So that just gives you a really quick overview, baseline of the Connecticut system, and then I'll turn it over to Jeff for some of the data and outcomes that we have.
Thank you, Tim, and thank you everybody for the invitation to be here. I'm Jeff Vanderploeg. I'm the president, CEO of the Child Health and Development Institute, CHDI in Connecticut. We do a lot of work with Tim and with DCF under contract to support a number of initiatives. So for this particular initiative, a mobile crisis, we're responsible for all the data analysis, reporting, and quality improvement activities, as well as standardized training curriculum to all the providers across the state. The first slide that we have to show you here just has to do with overall call and episode volume. There are, as you can see, at the high point before the pandemic, just over 20,000 calls. Some of those end up being triaged over if they're only for information and referral, for example, but not necessarily behavioral health referral calls. They may be triaged out, but as you can see, the majority of them on the blue line become mobile crisis episodes of care. We were over 15,000 episodes of care annually in fiscal year 19. You can see the dip that we experienced throughout the pandemic. And we're starting to see in our fiscal year 22 data return to pre-pandemic levels of utilization of the service. The major take home here, and in addition to just carefully looking and monitoring at the utilization of data, is that we have a value here in Connecticut around high utilization of the mobile crisis service. So we want our providers and our communities and our families and our schools and our police departments and everybody really to be calling mobile crisis. And it gets back to Tim's value and philosophies that he mentioned earlier, having to do with crisis being defined by caller, which sets a relatively low threshold for utilizing the service and makes it really more of a prevention, early event, or intervention service delivery model. Let's go to the next slide. So you can see here what referral sources look like over the last several years that we've been collecting data. For a long time, families and youth themselves were the primary referrers to our mobile crisis service. That started to switch around fiscal year 17 and 18. That was in part due to legislation that required school districts rather to execute MOAs with their local mobile crisis provider, in part to increase the number of children who were being referred to mobile, decrease the number of children who were being referred to the emergency department or juvenile justice involvement or other things of that nature. And then you can see how things have shifted throughout the pandemic as well. We anticipate we'll start to see numbers go back to schools being the primary for referrals over time once things start to return back to normal. And then you can see below what emergency department referrals have looked like historically, hovering around 10% plus or minus. A little higher recently. We've seen a number of kids presenting to the behavioral health emergency departments with a primary behavioral health issue. Major take home here is these are the people, families, schools. You don't see emergency departments. You don't see places like police and others here. But if you want to interrupt these pipelines of behavioral health emergency department volume, kids being inappropriately served through the juvenile justice system, or quite frankly, receiving no care at all, these are the referral sources that you want to provide outreach to and educate them about the availability of mobile crisis. Let's go to the next slide. We also in Connecticut have developed a number of performance metrics. Here are two of the major ones that we track and have tracked very carefully over time. As you can see on the left side around mobile response, we set a benchmark very early with our provider network where our expectation was for 90% mobility. That's pretty different from the adult-oriented model, which was where the mobility expectations might be lower. In the child-focused model, we really believe in the mobile face-to-face response. We established that 90% goal for the providers. They've been consistently achieving it for a number of years. You can see here, our statewide average this past year was nearly 96% mobility. On the right side, we similarly established a benchmark for our providers around response times of 45 minutes. And we wanted at least 80% of our mobile responses to take place in 45 minutes or less. And you can see that we've achieved that benchmark by and large. And in fact, our median response time, as Tim mentioned earlier, is around 30 minutes and has been for a number of years. So the major take home here is we really believe in establishing benchmarks and performance measures for our mobile response system. And then we carefully use the data to track performance against those benchmarks and work closely with our providers to help them if they're experiencing any difficulty through the quality improvement side of the work that we do. Let's go to the next slide. This figure shows you outcomes in terms of maintaining children safely in the community. This is an improvement in the measure of the Ohio scales. Ohio scales is the outcome measure that the Department of Children and Families uses for the majority of their contracted children's behavioral health services. We look at that data from pre to post, and we look at it from a number of different ways: partial improvement, reliable improvement, or clinically meaningful change. A lot of times, if you have a selected outcome measure in your state or community, and you look through the technical manual of the measure that you've selected, they may have some guidelines around calculating these levels of improvement. We've always been pretty surprised by the positive findings and statistically significant findings we see on the Ohio scales from pre to post. And we definitely see the evidence there of stabilizing crisis situations. Let's go to the next slide, please. Staying in this category of outcomes or expectations coming out of mobile response service, I think another key function for mobile response systems in a lot of different communities and states is that they play a significant role in referring and linking families to ongoing care. So you can see here that a lot of times that connection is made to outpatient services, and you can see a number of other levels of care and services below that to which young people are referred at the end of a mobile crisis episode of care. Occasionally, there might be no referral at the bottom of the screen that says 11%. We also have a high number of people, individuals who are referred back to an existing provider, which is captured in our data. But this helps us understand what happens after that mobile response episode of care, which can be quite brief. So one of the major roles and functions of the service is to refer and link. Let's go to the next page. We also think it's important to look at mobile response. I was speaking earlier about our value for high utilization and how mobile response can help disrupt other pathways, or sometimes you hear pipelines to other areas of care. So sometimes if you don't have a mobile response, you might find that youth and families aren't connected to services at all. If you don't have a high quality mobile response system, I think you're going to see a lot of kids who are inappropriately sent to an emergency department for a primary behavioral health reason, when many of those young people could be effectively served in the community and not need to touch the emergency department at all. We also see high rates of juvenile justice referral for kids who, quite frankly, are better served in the behavioral health system instead of really looking at the JJ system as a de facto mental health service. So we think it's important to look at a return on investment. We've done some work in that area to see how mobile response disrupts those pipelines. This slide has to do with averting inpatient hospitalizations, and we did just sort of a kind of I wouldn't quite call it a back of a napkin, but we wanted to look at our data from the standpoint of averted inpatient hospitalizations. That's a question that's asked anytime an emergency department refers to our mobile response program. The attending physician or nurse or whomever is calling is asked the question, is this a routine emergency department referral or is this an inpatient diversion? And there were about 480 instances in a fiscal year where they indicated it was an inpatient diversion for youth who are enrolled in Medicaid. If you look at the cost difference between an average inpatient hospitalization and the cost of an average episode of mobile crisis care, and you kind of subtract the difference from one another, those 483 inpatient averted care total up to over $5 million of saved costs to Medicaid. So it's just a way to think about how can you leverage your mobile crisis service, not just to provide good outcomes for kids, which is always the primary goal, but it also is going to save you money in other parts of your system, especially if you look at it in terms of a cross-system perspective. Let's go to the next slide, please. And in addition to inpatient, you can also think about diverting from emergency department stays, which I mentioned earlier. We did contract a study with partners at the University of Connecticut to look at, again, the Medicaid data and did a match and looked at emergency department visits over the course of 18 months. And long story short, what we found is that young people who use our mobile crisis service experience a 22 to 25% reduction in subsequent emergency department utilization over that 18 months when you compare them with youth who initially use the emergency department. And so we've talked about inpatient, we've talked about EDs. There's also a number of other potential cost savings in terms of residential treatment or therapeutic outplacement, out-of-home placements, arrest, incarceration. These are all outcomes we don't want to see for our kids that are also happen to be expensive. So mobile response can be a really important service for averting costs in those areas as well. Next slide. So that's it for us. We would love to hear your questions or comments. Let's go ahead and open it up.
Righty. Well, first and foremost, thank you so much for the wonderful presentation. Also point out that it was a lot of material to bring together, but in a somewhat prejudicial sounding sense, I had the opportunity to hear it from before. So it was just a wonderful display in the brief period of time that you've been given. There are a number of questions that have popped up in the chat box, but before I even go into any of those questions, let me just first and foremost, as a reflection of what the states have been talking about, the whole key behind your mobile response. Some of the states are talking about challenges that they have to even initiating this mobile response thing. Is there any guidance that you could give as far as implementation of your mobile crisis settings?
Yeah, I think so. One of the big things is really we built into our contract ongoing and routine outreach and education. We came up with a standardized presentation of 12 slides, and we expect them to do outreach to all their local community members on an ongoing basis annually. And they tend to do it mostly during the summer when it's a lower peak time, but they are required to do that. The other thing is ultimately, particularly with law enforcement, you got to earn your credibility. So until you actually work well with them and they have some experience was they feel like the response was really well done for them, it tends to work in our favor. And lastly, I would say one of the other things we do CIT training with them for particularly on the CITY, the youth component of that. And we co-trained with law enforcement for quite some time for a number of years. And in that process, we got to know a number of the local law enforcement jurisdictions, then that really helped also. So there's some concrete activities, particularly outreaching to special populations, law enforcement, schools, foster parents, et cetera. Those are really key. Other questions you want to facilitate?
Okay, I have to apologize. My signal goes in and out, but I did have a question that was related to what you were talking about. There was one question that was placed in the box that said, how do mobile crisis response teams provide response to youth in your federally recognized tribes or reservations?
Yeah, actually, by agreement only, I think generally speaking, the tribes tend to handle their own calls. They have a system on their own. But if in fact we get a call, I think our local providers have the contact information at the tribe and will only go on with permission and all that. Generally, we're not invited that often.
Okay, well, thank you. Another question raised was, do you have structured processes for engaging and educating families both during and following the crises?
Yeah, so I alluded to before the crisis, again, there's these general outreach activities. During the crisis, again, they're the service is reviewed with them, particularly after the acute phases stabilized and things have settled down. And folks are educated on it. They can call back multiple times. But generally, if the episode of care is still open, that means that if the clinician leaves the house and there's another follow-up appointment, that clinician gives their cell phone number to that family. So this family doesn't have to go through the call center again during that episode of care. If the clinician leaves the family and the episode of care is closed, there's no follow-up appointment schedule, the family can call back the next day anyway. So it's just that they have the direct clinician who's been assigned to that episode. So that's all got done. And then the crisis safety plan is reviewed with the family on kind of who should be the folks that help stabilize the crisis within the context of that family, and what are the informal supports that help with that.
Wonderful. Thanks, Tim. Another question that was raised was about your use of, or do you have certified peers or volunteers?
That's one of the things that when we structured our enhancement a number of years ago, it was allowed, and we do mention it in the contract. Our providers have not utilized it as much as they could. It's getting a lot more attention right now. So within the contract, they can hire them, peer support specialists. And in fact, the providers that have used them in the past use them on the follow-ups and the ongoing linkage to care. So that's how they're most effectively used. And currently, a number of the providers are looking at adding them now in ways to enhance, because the master's level folks have been so difficult to recruit. So it's another strategy that they're trying to use to overcome the workforce shortages right now.
And I noticed, Tim, there were a number of logistical questions about data collection, data acquisition. One says, how are you tracking the outcomes of the children who are diverted from inpatient?
Yes, and Jeff touched on a little bit of that, but anybody can go to our website, and we have quite a bit of data. We publicize all of our data. It's fully transparent, and you can look at them in detail on Mobile Crisis CT in Connecticut, Mobile Crisis CT Connecticut, and you'll find the data there.
Wonderful.
And just to add a little bit to that, I mean, we have not looked specifically at the outcomes of that subset of young people who are diverted from an inpatient hospitalization. But as Tim mentioned, we do collect and report out on outcomes for those who use Mobile Crisis. We certainly could, we subset out those young people who are diverted from inpatient. We have not done that up to this point, but that could be done.
Oh, thanks, Jeff. Well, just a couple of more questions. One came up. How do you calculate the number of mobile response teams that you would need in a particular area, say it's rural or urban areas?
Yeah, so when we first developed our enhanced model back in 2009 and 2010, we used quite a number of sizing the system kind of criteria, particularly child protective service referrals, teen pregnancy, a whole bunch of those. And we also based it off of historic views of need of our entire behavioral health system. So we came up with approximately how to size the system. We did a decent job. We did shorten one area for the first few years. And then as our data came in, it became much more precise. And so we've been able to add enhanced funding to the areas that were historically underfunded. And then we're able to much more readily be able to slice the system in the way in which it's intended. So right now, as we're moving towards 24/7, our data shows us very well exactly what percentage of the total number of episodes of care are served by our 6 providers. So we have a pretty good handle on that. But specifically to the question, we actually don't require them. We give them their money, and we don't actually articulate how many FTEs they should have and when they should have them. We just basically say in our contract that they have to cover the neediest times with the staff that they have. So they figured it out very quickly. In the first year, 6 to 9 months, they really figured out where their staffing patterns needed to go and how do they need to staff their daytime hours, their hours.
Well, to both you, Tim and Jeff, I want to thank you so very much for brilliant presentation, very helpful information, very open. We thank you for presenting, and I know it was difficult to compress it all into that timeline, but we're certainly appreciative for what you provided for it. It gives us a lot of new useful tools for our toolboxes as we begin to measure how we can do parallel things with this crisis intervention, particularly targeting our children and youth. So thank you both again.
Thank you.
Thanks a lot.
And let's move forward. Next slide, please. And we are at the level of our roundtable discussion, the crisis trivia hot seat. And I believe we have Shelby with us today. Am I correct in that? Are you with us, Shelby?
Yes, I am.
Wonderful. So great to see you. We have today, under the same guidelines, the trivia hot seat question for you. And in this question, I'll go ahead and read through it and give you time to contemplate, but you have a lot of options to work with here. You can either answer it on your own if you know it already, or you could poll the audience, call a friend, do whatever you need to do in terms of addressing the question. So we're okay with that?
I am. And I saw this question and I was happy because I thought, I think I know this one right off the bat, but I do want feedback from everyone else just to make sure I'm going in the right direction.
Well, definitively we will do that. So let me real quick. The Press One Veterans Crisis Line has grown from its launch with Dr. Jan Kemp and Samsa in 2007 and 14 trained staff to hundreds of responders nationwide and online chat and text. So your question is, where was the Veterans Crisis Line originally launched? And as you had already pointed out, we've already put the poll out there for the audience to give response to. So you've got that available to you as well. You can choose to use that. You can choose to go on your own, or you can go with a friend. So let's give it a few moments and see how things have turned out. And the response is coming back, as you can probably see, pretty scattered, but it seems like it seems to favor Canandaigua, New York.
All right. Well,
your take.
Yeah. So back in, I think it was 2008, I went to an assist training sponsored by the National Suicide Prevention Lifeline because I was running a crisis center in Arkansas at that time. And one of my classmates was from this Veterans Crisis Line program. They were a shift supervisor and they were in Canandaigua, New York. So that is going to be my answer, that it was Canandaigua, New York.
Well, let's see if you are spot on, and you are indeed. Very much so. So it is Canandaigua, New York. Thank you. Again, you get the gold star. We haven't quite decided as a group what it means, whether you get a trophy, money, or just a nice little pat on the back and move forward, but you did great. Thank you.
Right.
Thank you for being such a wonderful participant in this.
Of course, this was fun. Thanks for giving me one that I had some knowledge of. I was a little scared it would be in an area I had no information, but I knew the group would help me out no matter what.
All right. Well, thank you again. Now let's move to the next slide. We have now reached the portion where I'll be calling on Stephanie to give us an update.
Hi, Brian. So I'll actually be introducing Miriam Pearsall, who's an executive fellow at Wellbeing Trust, and she's one of the authors of this week's article. Welcome, Miriam. Can you give us a brief description of this week's article?
Sure, I'm happy to do that. Thanks for having me. And also, I just quickly have to say I'm originally from Arkansas, so I appreciate the Arkansas love in the chat. So again, thanks for having me. I'm here to talk about this brief that was co-authored by me, my colleagues at Wellbeing Trust, Roxana Rodriguez and Laura Blank. And we decided to write this brief to understand at a high level states' needs for strengthening and investing in home and community-based services specific to mental health in the crisis continuum, especially keeping in mind that HCBS is traditionally associated with seniors and those with intellectual and developmental disabilities. To glean this information, we evaluated state spending plans for the American Rescue Plan Act, ARPA, Section 9817 funding, which provided qualifying states with a temporary 10 percentage point increase to the Medicaid, to the FMAP for certain Medicaid HCBS expenditures. States will have until March 2024 to spend the additional funding that they draw down from the match.
Miriam, do you want to, oh, I'm sorry. Do you want to share a little bit about what some of the state spending plans look like in terms of expanding crisis support?
Sure, absolutely. And just real quick, in our analysis, we found that states were specifically mainly asking for increasing provider pay, bolstering the workforce through development, and supporting the crisis continuum. One state stood out in particular, which was Washington State, and they specified using $6.5 million of their funding to receive the match to establish at least one adult and one youth mobile crisis team in each region of the state, and also supporting their continuum with substance use disorder family navigators, an opioid treatment network, and a rural behavioral health pilot program. Also, there was New York and other states who were interested in the prevention side of the crisis continuum, so supporting youth with services and therapeutic interventions that rely on clinical staff and peer advocates.
Well, thank you so much for hopping on the call and sharing this information. I hope everybody goes to Crisis Talk and checks it out. Thank you.
Thank you.
And thank you, Miriam. Thank you, Stephanie, for a wonderful update. And now we'll move to our Samsa update. So we'll start with James Wright.
Hey, thanks, and good afternoon, everyone. So a couple quick things from Samsa. I want to first start by thanking NASHBID and McKinsey and all those that participated in the Samsa convening process. We wrapped that up at the end of the month, and it was tremendous seeing the level of effort and engagement across partners, just the spirit of 988 and where we want to take it. So just huge thank you to all that were involved. And just for everyone else to be prepared that we have some operational playbooks coming out. Really, these are for assessing readiness across a couple key areas. One is for a PSAP operational readiness playbook for linkage and improvement with 911 and the public service access points. Also a provider playbook. One for states and territories for their 988 readiness, and then finally one for Lifeline crisis centers directly. So those four are being finalized, and to my knowledge, hopefully will be ready within the next week or two. That will be coming out of NASHBID, and Samsa will also put a link on our site. And I'm just assuming that everyone will hear about it on one of our upcoming calls here. So please definitely continue to join us and stay tuned. So thank you for the tremendous efforts there. Secondly, I also want to make sure individuals are aware that our 988 state and territory grant program is about to kick off. We are anticipating awarding those funds here in the a little bit less than 2 weeks. And then afterwards, looking at those activating by the end of the month. So really getting everyone on target for that funding, those funding awards and the implications of the actual grants, the workforce improvement process, and just tracking that for readiness for 988 response. So very excited to be kicking that off. So it's going to be a busy month for all. Any other individuals from Samsa on that want to provide any updates? Not hearing any. Brian, back to you.
All righty. Well, thank you. And again, I want to emphasize being thankful to Samsa for the tremendous leadership that you guys have had in terms of guiding us through. So thank you all. And we'll move now to a NASHBID update from Dr. Brian Hepburn.
Thank you, Brian, and thank you, James, for the Samsa update. We've enjoyed participating with Samsa in the 988 preparedness, and we think the convening was very successful. We look forward to the next steps, which will be coming soon, and also to the playbooks, as James said. We'll hopefully be notifying everybody in next week's jam or the following week's jam where to get those links. Want to also thank the Connecticut team, Tim and Jeff, talking about child services. And I know there was feedback already, but I just wanted to point out that one of the things I think is really good, and we'd like to see the information on, is the legislation that was passed to make it mandatory for schools to form agreements with crisis programs. So that seems very innovative and makes a big difference in terms of that connection. So we'll work to get a copy of that and see if we can then distribute it to everybody. In addition, a big issue that the states are working on is workforce. And we know all of you on the phone are very familiar with that. And we're looking for innovative ideas for recruitment, retention, and also ways to decrease the demand on the workforce. So hopefully we'll have some ideas on that soon. Next slide, please. Let me turn it over to Megan Hope. Megan?
Thanks, Brian. I wanted to just add a little bit about Tim and Jeff's presentation. It's extraordinary that that they really brought some takeaways. And one was that the mobile crisis was a way to do early intervention, was a way to also connect to further services. And it gives that emphasis of how important it is to build out the crisis service system, and that the crisis is defined by the caller, and that helped so much with that early intervention piece and the averting to those higher level services. So I just wanted to note that what an extraordinary state example, and to call on them if you're looking to do mobile crisis in your state or your area. Also wanted to emphasize a few resources, one being the Crisis Talk article recently done that Dr. Sharon Hoover did. She was a topic area on how schools are stakeholders in mental health crisis. There are also NASHBID papers that we want to highlight. One is improving the child and adolescent crisis system, shifting from a 911 to a 988 paradigm, as well as making the case for a comprehensive children's crisis continuum of care. So we hope that you'll take a look at these papers. They're on the Crisis Talk website as well as the NASHBID website, and those should be being posted into the chat. So thank you so much. Back to Brian.
Thank you, Megan. And thank you, Brian, for that wonderful update. And we'll move now to our federal updates. So Sarah, take it away.
Thanks, Brian. If we can go to the next slide quickly, I will go over an energy and commerce legislative hearing that happened yesterday. It's in this top right box here. It was on mental health and well-being legislation. There were 19 bills included as part of that hearing. The first panel included the Assistant Secretary Delphin Rittman, as well as Administrator Johnson from HRSA. And the second panel had witnesses, including witnesses representing NASHBID, NASDAD. There was a peer, an APA witness, and then two from the pediatrics and children's mental health space as well. It was a really great, very long hearing with a lot of great content, but one thing I'll flag in particular was a shout out from the Assistant Secretary to the Crisis Jam as part of the preparation for 988, including all the different states and this weekly call. So she specifically shouted out the Crisis Jam, and also included in that hearing was in particular the 988 and Parity Assistance Act led by Rep. Cardenas and Fitzpatrick, which is a part of that, a combination of that parts of the larger 988 implementation bill that we've talked about previously, as well as the Cardenas parity bill. I will turn it to Joanna to go over a few more hearings. It's been a busy week in DC.
Yeah, I'll just briefly highlight the Senate Finance Committee hearing that happened yesterday, which saw Secretary Becerra join the committee to speak on the HHS budget for FY23 as part of his committee tour. He highlighted 988 in his testimony, so it was great to hear that. And then just quickly, as an aside, the Senate Armed Services Committee also had a hearing today, non-budget related, but still noteworthy. It was on suicide prevention and behavioral health intervention for service members and veterans. And that saw a lot of great testimony from particularly the Director of Defense Suicide Prevention Office at DoD, as well as veterans with their own experience and experts in the field to offer insight into that. So that was really important and great to see the continued prioritization on the Hill.
Righty. Well, then, thank you both for that wonderful update. And as we move forward, let's go now to talking on the states. And Jordan, I believe, from Vibrant.
Yeah, thank you. Thank you, Brian. I'll get us going here and kick it to Steph in a second. So a couple quick updates. So Maryland House Bill 293 passed the legislature. So that is now awaiting the governor's signature. And just a refresher on that bill, that is based off some Model 988 language, and that creates a 988 trust fund. And this bill specifically appropriates $5.5 million for call centers in fiscal year 24. And Illinois also recently passed Senate Bill 2945, and that bill would also create a 988 trust fund. I'll also just highlight two bills that have been recently introduced. One in Minnesota, which is part of a larger healthcare spending plan that establishes a 12-cent fee. And in Connecticut, kind of similar, a larger children's mental health care spending bill. That is House Bill 5001, and that currently includes a 75-cent 988 fee provision. So just flagging those for awareness. I will kick it over to Steph to talk a little bit about Washington State.
Yeah, thanks, Jordan. Some good news out of Washington State. So House Bill 1688 was signed by the governor. And this bill protects patients from surprise billing. But in terms of 988, what is significant here is that this bill creates, or law now creates, an insurance coverage mandate for behavioral health emergency services, including mobile crisis response, crisis receiving, and stabilization services. So really exciting to continue to see Washington State be a leader in the 988 policy space after passing House Bill 1477 last year as well. And just a reminder as well that NAMI and our partners, we also continue to host monthly meetings for 988 state advocates who are working on legislation and want to chat about some of the successes and challenges that you might be experiencing and trying to move these bills forward. And I will post in the chat in just a minute how you can get signed up for those calls that happen on the first Monday of every month at 4 p.m. Eastern to get those on your calendar. And that's all the state updates from us.
Well, thank you so much for that. And I'm just wondering, since we have a little bit of time, if we have any of the states that would like to maybe make a comment on their particular updates. We're seeing it through Utah, and if we have anyone from Nevada, I would just like to make a speak on Washington State as well. All righty. Well, then we will go ahead and move forward then. I'm going to get into this wonderful slide. This is all about now being able to access the crisis calculator, calculator.crisisnow.com. And I was going to ask, Paul, if you're available, if you wanted to comment a little bit on this.
Sure, Brian. Look, it's McKinsey did a fantastic job kind of showing the new innovative changes that have come forward in the design, and hopefully some of you have gotten a chance to get in there and play with it a little bit. But all that said, there were a few questions posted last week, and I'm sure there are going to be more. It is new, it is a bit different, and wanting to know some of the assumptions as well. So I did just post my email address in the chat. I'd be happy to get in, provide more details, walk some of you through it. Again, I think it's far more user-friendly than the original iteration. But at the same time, it's different. And there will be questions about assumptions and how you can edit these. And the fantastic news for those of you doing the work, I see Karen getting into Connecticut, it looks like, and you can go county by county. You can start editing the drive times, what it looks like for demand, the costs in your area. It's really amazing. And in fact, we'll also get you into the deeper dives of demographic populations you would reach based on the services you implement. There's just so much there, Brian, and it would take a long time for us to go through the entirety. But again, it allows you to project some of the demand, project some of the costs, and happy to walk through that with anybody.
Well, definitely we want to thank you for making yourself available in that regard. And I would encourage you all to take advantage of that, because again, coming into this and looking at the way that it's structured, getting some guidance to get it started will be immensely helpful to seeing how facilitative it's going to be and how helpful the information is going to be for each of us to be able to use. So thank you, Paul, for being a last minute step up to the plate for us. I appreciate it, man.
Thanks, Brian.
Alrighty. Okay, well, let's go to the next slide, please. And this is a reminder again about Moving America's Soul on Suicide. We're at the episode 5. We encourage you to continue to observe these and watch them, because again, our movement has so many directions that it is taking, but we don't want to lose sight of the immense issues, be it through COVID or just general crises or traumas in individuals' lives, the immense focus that needs to be maintained on suicidality. Next slide, please. We've actually reached towards our end for today, but beforehand, I just wanted to highlight one big one on here. You heard a little bit earlier that our Assistant Secretary of Samsa, Dr. Miriam Delphin-Rittman, had spoken very positively about the Crisis Now and Crisis Jam. I just wanted to remind you all that upcoming on the 13th of July, she is scheduled to speak during the Crisis Jam. So we invite you all to make sure that you're available and come on that particular day. But before that, just giving you an outline of who's coming up in the near future could be very helpful information. You've got Dr. Chuck Browning and Dr. Robert Coates that are going to be talking on role of medication in crisis care, and that comes up next week, followed by Dr. Marcia Ford talking on 988 from poison control and lessons that are learned there. Dr. Palmieri from Samsa, through John Palmieri, is going to be talking on the operational readiness, really key component, on April 27th. Make sure we're part of that. We have also folks from the Vera Institute and as well Nancy Kirshner speaking on CMS crisis opportunities, and Dr. Carol Olson talking on comorbid medical and crisis. We are so thankful for the input each and every you have given into this process, and we're encouraged by the fact that we have so many people, and we at this time encourage others to join on the line. And if there are any, access our line. Thank you, every single one of you for participating. And we're going to do something a little weird today. We're actually reached the end a bit early today. So I'm going to say, everyone, please have a wonderful rest of the day. Enjoy yourselves, be safe, and we will see you on the next Crisis Jam next week. Thank you all again.